Can you call Guhan to do the quiz? Guhan, we are not able to locate the ICMR madam. I have told her yesterday that tomorrow I'm waiting for the closing talk. Who? Ah, Smita. She's coming? Yeah. Okay. Okay. Uh, she's coming. She's uploading her talk in the faculty lounge. I would request everybody to please fill up the feedback form because that only can improve our next conference. What is to be done? What are the things to be taken? Madam, we are waiting for you. Where is Ravindra? Please call him because he need to chair and introduce you. Bhavesh, Ravindra is outside. Just tell him to come. Madam, please come. Uh, so everything which is start has to end. So we come now to the closer end of the scientific sessions, and this is the last scientific oration which we are on now. And to give this, I have Professor Ashoo Grover, who is scientist and head division of delivery research, implementation of research, ICMR headquarters, New Delhi. She has been involved in various projects, allocation, funding, helping us, various positions he has in the past, many research chapters, and it was her kindness to accept the closing lecture for us. We are thankful to you, madam, and we look forward to your talk. You gave a topic which is very, very important because yesterday, full day, we were talking about rehabilitation 2030, and the neurologists really did not know what is 2030 when I asked them. So it is very interesting and very important that you give us your oration on neurorehabilitation 2030 opportunities to young rehabilitation specialists in India. Madam, over to you.
Good morning, everyone. It is really a very, very proud moment, and I'm privileged to be there among the august audience and a conference which is of very much great importance in today's context when we have lot many things going on in different directions. We are moving towards different kind of problems, burdens, not only in our country but globally as well. And having these conferences being held at an international level in India really makes a difference, that we happen to hear from the global fraternity as well as the Indian perspective and Indian researchers. So first of all, I really owe a large, huge thanks to Dr. Nirmal Surya, who is a master brain behind organizing this conference to such a magnanimous, in its advancements and the whole arrangement which has been done over here. So thank you, Dr. Nirmal, and who could gather all the fraternity across the world and different parts of the India to talk about and deliberations on the context which is emerging. I will not say it is emerging, but maybe it existed, but nobody paid attention to this very important aspect of this improving the quality of life and improving the functionality of the people who are suffering from chronic diseases. So I will be taking around 20 to 15 to 20 minutes spending on that what has been done by the government, what has been the ICMR vision, and what are our future pathways to take this neuro rehabilitation program across the country through its various initiatives. So, I, being coming from Indian Council of Medical Research, many of you must have been aware that what ICMR is. If not, then COVID pandemic really made its more significant contribution in terms of its vaccines and preventive and other strategies, which became the organization more and more. So, ICMR is by and large a funding agency which promotes health research in its different areas, not only for a specific area which we talk about here, but it spearheads the entire research spectrum of conditions starting from preventive to rehabilitation, starting from communicable diseases to non-communicable diseases, which includes the reproductive, the nutrition, the pediatric, the maternal, and whole sort of. So we will talk about each of these in a very short while. So coming back to the main focus of the discussion in today's 15 minutes of deliberations, we all know that rehabilitation is a key uh, as an outcome of the various conditions. And I'm sure that there must be some experiences of most of you who must have encountered some or the other patients within the family, within the society, within the neighborhood, or within your own context. The patients who must have been having the outcome, the after discharge treatment of the stroke or the spinal cord injuries, or maybe the traumatic brain injury, the neurodegenerative disorders, or so on. So, I mean, the care of these such patients starts from the hospital, but there is a whole cascade of the care which involves even after the patient has been out of the hospital, so which we call it as a rehabilitation. But if it is related to some neurological condition, we call it as a neuro rehabilitation. So it is taking those patients, taking those people to a long term, preventing them from having a long term disability. And the care need to start from the day one, the day of hospitalization, or whatever we can provide it and extend it beyond the limits when the acute clinical care is over. And I must say that the most of the role is being played by the caregivers, and the caregivers in this case mostly belongs to the family. So most of the neuro rehabilitation activities and the programs, of course, need to be given by the family members, whatever the cause of having those neurological disorders or neurological deficit may be there in any of these conditions, be it because of the TBI or the spinal cord injuries or the stroke. So I happen to have some of the members in my family, two members in my family, which really had the spinal cord injuries, and they happened to have the whole life later on spent into the bed, and they needed a lot of care, not only from the lower limb perspective, but the whole of the body perspective, and lot many things go to the family care perspective. So that is how we need to have some kind of a systemic continuous intervention strategies which keep coming on from the researchers like you, and by discussing having these debates in these conferences. So as I said, that the neuro rehabilitation program starts not only from the family, but it starts way beyond when the patient is admitted into the hospital. So in the hospital, there is a whole lot of the physicians and the nurses and the entire physiotherapist and other the hospital patients who look after that patient, whatever the case it may be. But the real systems driven ecosystems start the patient has been discharged. So the patient has been discharged and we need to have current modalities, new innovations, and the robust infrastructure, be it at a health system level, be it at a community level, be it to be delivered by our Indian public healthcare system or whatever healthcare system across the globe it may be, but it need to have a updated one, and that updated could be done through the innovations, the ideas, the integrated research environment, and of course, coupled up with the some of the innovations which could be digitized, the robotic, or whatever the new innovations may come up for improving the functionality of the patient, for improving functionality of that particular one person who has been discharged from the hospital after having some neurological. So, what neuro rehabilitation we need to make ensure that we are able to, what ecosystem, what health system, what the community system, what the family system should be so much geared up by guaranteeing that the continuity of the care is being given from hospital settings to the community and to the family settings by and large. So, from Indian Council of Medical Research, I've specifically taken it out some of the key initiatives and what are the 4 or 5 mechanisms to which ICMR has been contributing in this area of research in its own way. So, in one of the initiative, we fund the clinical research. So, one of the pillar is for advancing the research agenda in neurological disorders, not specific to neurorehabilitation, but to the neurological conditions. We do fund the clinical, researchers across various parts in the country, and we have a reach to almost every medical college to improve the clinical care, to improve the clinical research outcomes by supporting the research projects in various ways. And I happen to be the program officer for the neurological research program around a decade ago, where I could know that what are the different programs which is being contributed either in the form of the stroke or the traumatic brain injury or epilepsy or an elderly program. So one of the pillar that ICMR has been contributing and still contributes in its various domains by strengthening the researchers by providing them the grant to undertake the clinical networks. Another main pillar is that we fund an infrastructure in terms of the innovation engine. So what I mean by saying that, we as a Department of Health Research have various platforms. I don't know how many of you have heard the MedTech Mitra and the Patent Mitra, and we have developed these two major platforms across the country, which can help the innovators and the researchers to come forward and have the idea. So the idea of having these Patent Mitra and MedTech Mitra is whatever the newer innovations do you have, taking those innovations right up to the industry level or to the production level or to the manufacturing level. So all of us know that when we have the hackathon and a workathon or a mentorathon or whatever we do that, there are certain incubations or the innovations or ideation we do not reach up to the end level. So I think this is the message which I want to give through this session of mine, that we have the MedTech Mitra. Mitra in Hindi means is a friend. So we have the medical technology friend, which can help the ideators or innovators to seek help from the ICMR platform, and we connect them to the various industry partners, to the manufacturers, to the commercialization, and even to helping them to take the CDSCO approvals, whatever the national, appropriate regulatory approvals are there. So ICMR does help them in connecting them to the taking all the necessary permissions. The whole aim is to make the patient, to make the research outcomes available from individual to the family and to the community. So that is the pillar 2. Third is that assistive technology. ICMR has been becoming a global leader. Now I can very proudly say that very recently, when ICMR, the Division of Disability Rehabilitation and Assistive Technology, has been granted, announced as a WHO collaborating center, so it has become a global leadership, and the champion is sitting right in front of you, Dr. Ravinder, with whose efforts that ICMR has little been, taking the level up in the area of assistive technology. And I think that is a very good example in a very short span of time. And I will say it is the one program which I am witnessing from last 1.5 decade, that very short span, it has reached its height from local to national to a global level. So that is one contribution, that we are demonstrating the products, we are demonstrating the procedures, we are demonstrating the validation, we are demonstrating the partnerships. The biggest thing is that when we say that Indian Institute of Technology in our country is a hub of mechanical a counterpart, and AIMS is a clinical counterpart. So this is a program where these two are working so closely with each other, and all the national organizations are bridging the gap in making the things available to a common man in the form of assistive technology and assistive products. Lastly, the fourth pillar I would like to emphasize is digital health and the scale, where we are committed towards the Developed India Viksit Bharat 2047, and these things are monitored very closely. I am very sure that some of the products which are here as a deliberation come out of this conference, sir, IFNR. So some of the newer products can be there as a futuristic technology, which India can definitely, embark upon and put it as an outcome when we label and announce as India Viksit 2047. And large number of funding has been allocated to make the India 2047 as a developed India, because we as a policy maker are witnessing it, and the Prime Minister office is quite, closely monitoring what are the technologies which can be easily taken up to the population level through these pillars. Another initiative, that, as I said, that when we fund the clinical networks, so one of the network which I think probably many of you must have heard of, if not, then we call it as an Instruct network. So this was a stroke clinical trial network, and of course, for running any program in such a big manner, we need champions. And I must, very proudly say that in India, we don't have any dearth of having such leadership and quality professional researcher as well as experts. And I can really find Dr. Vadva sitting in the audience, that who has been the champion in the physical medicine and rehabilitation in his own department, is one of the champion, not only for a construct but for various other initiatives. So similarly, the Instruct network, which was initiated by the Christian Medical College Ludhiana, Professor Jayaraj Pandian, and it has expanded. The only aim of having that Instruct network was to have the multiple clinical trials in the area of stroke, and making the stroke survivors as a kind of a, making them rehabilitation and harmonizing all the treatment protocols of the management of the stroke as well as to the rehabilitative framework, so that there could be India specific clinical evidence which comes up, that how we can through Instruct various clinical trials. This trial is coming to an end, and hopefully the outcome of this Instruct network, it started in 31 sites. Now, based upon its success and inclusion other criteria, it has been extended to 100 more sites across the country, and it is, still going on. And hopefully this is going to change the whole paradigm and the health systems levels of care, that how we can improve at the primary level, starting at a specialist level of care through the Instruct network. Another initiative, and we just was that, for the specifically for the ICMR has done a lot of work in the stroke management, apart from other neurological disorders. So stroke has already been, because this this is one of the situation condition where there is a lot of post discharge and post clinical care is required at various levels of setting. So to make rehabilitation, or to make appropriate outcomes, improved outcomes from the stroke patients, we thought that one of the major thing which can be there, that these patients reach to the facility very late, and especially in the rural areas, and that came from various epidemiological and the survey parts, that the patient reaches to the facility at a very later stage, where some of the things are irreversible, and we do not have the appropriate referral mechanism in our country, unlike in national health system UK, where the patient lands up to any of the facility, and he lands up to the nearby facility, and they say that we do not have any treatment protocols for the patient having stroke. So either the doctor is not able to recognize the symptoms, or the medications are not available. So what happens, the patient loses the golden hour, as well as the acute onset of that particular condition happens to be. So in order not to have and to take up the advantage of not losing the golden hour, so that divide was bridged up, that we had the mobile stroke units as a pilot project, which was initiated in the area of neurology, to have reaching the stroke unit directly going to the patient. And we had the similar kind of initiative by AIMS with the mobile bike initiative was also done, so as to avoid the this golden hour, so that the intervention, medical intervention, can be given as early as possible. The entire aim is to have the better functionality outcomes, because if there are this something happens, is a delay in the treatment, same is not going to have the outcomes of the patient, is also not going to be so better in terms of the some of the paresis or whatever happens at the post clinical trial. So this is one example, that through these such innovative approaches, be it is a bike initiative or be it a mobile stroke units, similar ideas may also come up. So through this mobile stroke unit, which recently has been transferred, because this was done in a project mode by Indian Council of Medical Research, but some of the state governments came forward, and the government of Assam, they came forward and they took the liability that whatever expenditure has been done for the mobile stroke unit, we will take this unit as such, and rest of the expenditure can be met by the government. So the aim of telling me over this platform is that, so there may be certain initiatives, but ultimately for its sustainability and it for its scalability and to all time to come, for its own population, such innovation, such ideation need to be taken up by the health systems. That is how we are able to improve upon whatever area of concern we have for research angle or from rehabilitation angle. Another component, again, it was a part of the mobile stroke unit, wherein in the state same unit, it is a mobile van where the digital imaging, whatever the necessary investigations had to be done, was done during transit of the patient, and they were transmitted directly to the doctor sitting at the referral point where the patient is going to come, so that early planning intervention can be planned. So what drug to be given, what investigations to be done, so that it can plan it out the rehabilitation phase of that patient also early. So that's the whole aim of having the mobile stroke unit, and this has been successfully completed with support from Indian Council of Medical Research. And any such further programs, if this conference emerges out and anything which comes out from researchers like you, are most welcome to approach Indian Council of Medical Research, so that we can take such models, either it's an AI model or a digital model or a imaging model or a telemedicine model, can be further taken up to the program for the betterment of the outcomes of the patient as well as of the caregivers. But how do we do that? So it is very, very important for you all to understand that how much budget are we investing into it. So I deliberately kept this one particular information for all of you to know, that recently we have modified our financial structures based upon the scope of the work. So you can see that on the left hand side, we definitely fund the centers for advanced research. So these centers for advanced research are high volume centers, high expectations from the impact point of view or from the outcome point of view, and greater ideas are funded by ICMR in terms of the Center for Advanced Research. So this is very, very large amount as per se. It is 15 crores money which goes into one Center for Advanced Research for over 5 years. And right now with ICMR, we are running around 40 to 43 Center for Advanced Research, with a country of so many researchers across the various institution specializations and for the private institutions also. This number is still very less because we need to solve out many problems. So if I recall, I mean, these whatever Center for Advanced Research are ongoing currently, undertaking the work in various areas. But I guess in the area of neurology, and we don't have any Center for Advanced Research in neuro rehabilitation, but definitely in neurology, in stroke, we definitely have 2 or 3 Center for Advanced Research. But what is the primary focus of Center for Advanced Research? It is interdisciplinary. Interdisciplinary, what I mean to say, if you have any digital intervention, if you have any robotic intervention, if you have any AI based tool, they are developing. Of course, IIT or any AT or any IT platform can join the clinician to, and not only the clinician, but even to those who can manufacture it further, who can take it, test it further to a larger population group. So we need to have a high impact interdisciplinary translational team of researchers which can take the findings which are already proven to the population or to a tertiary care center. So that is the prime focus of having Center for Advanced Research. And as I said that we did fund 3 centers which involve the brain computer interface, one, and one we have it on robotics, and one we have it on neuroplasticity. I'll let you know in the subsequent slide. Another bigger initiative is collaborating centers for excellence. This is a new domain which ICMR has recently started, and I think 3 4 days ago this call for proposal was just closed. Now what does it mean? That any of the organization, be it a federal government or a private institution, they want to collaborate with any of the ICMR institute, they can submit the project. But the only aim is that the scope of work is to be little less. So their aim is to have, some standards of care and capacity building of the institutional between private and the private partnerships can be becoming more stronger. So with that aim, we have the collaborating center of excellence. Only thing is that we need to identify any of the ISMAR institute working in that area, or any private organization or a public organization who really want to have working together within ICMR system, so they can apply to the collaborating center of excellence, and there are some financial outlays attached to this also. The third bigger component is the investigator initiated, which are called as an extramural grants. And we have called it as a small grant and an intermediate grant, which is Anveshan and Nishchayak. So Anveshan is a small grant up to 2 crore, and Nishchayak grant is a bigger grant which is up to 8 crores. So in this area, since I am looking after the projects related to implementation science, so I have I mean, 7 to 8 research projects which are working on neurological disorders. Of course, I don't have any project in neuro rehabilitation, but I guess maybe once I am there, so I would like to motivate you all to send me projects specifically focusing on neuro rehabilitation, so that we can do, this area as one of the important area, because this neuro rehabilitation does not only belong to the clinician, it really needs to move out of the context, and it is an interdisciplinary in approach. So we need to have a models through extramural grants which can be scalable, which are context specific, and they can be workable in different diverse Indian settings through its Indian public healthcare system. So another opportunity which I just would like to explain and tell you all, that within the Department of Health Research, when we talk about the young career building opportunities, so this is one platform. Any of you, we have found out, we have carved out the fellowship program, and this fellowship program is for the young researchers. So what does it mean? That we have two fellowship programs. One is the fellowships within the country, fellowship programs abroad also. So if anybody who is a budding researcher, young researcher, PhD student, or any disciplined person wants to go and work in any of the Indian institution, ICMR can give you the support financial, and ICMR will bear your all travel, your stay, and some of your honorarium and daily meeting expenses to meet that fellowship program within the country. Across the borders, international fellowships are also welcomed, and wherein the fellow who is an applicant has to be a permanent faculty in any of the institution, whatever institution you are working in. They need to identify the in university or the abroad international organization, apply to that. You need to have certain formalities to be completed, and that is purely on the selection base. So all the details are available on the Department of Health Research and ICMR website. We have the international fellowships up to 6 months, and some of the young researcher can go abroad and learn the newer rehabilitation techniques, newer stroke management program wherever in the globe, in the international institution you have found out. We will support you, but it has to be well written. It is competitive, and it needs to have a good outcome. So whatever you go out for learning, you have to give it return on investment to India. So with that mission, and there is one more lucrative thing which is added on to this fellowship. Whosoever has gone and learned the international fellowship program in the faculty, they need to come back, and we are going to give to you a project worth rupees 30 lakhs for a period of 3 years to undertake that work which you already have been learned across the international fellowship program. For the females, for the women, we have a special clause, the women break-in career. So because we do understand that there are certain compulsory family engagements from the women's side, from the female side. So we have a separate call under this broad category of the DHR ICMR International or National Fellowship Program. And there is again a competition, but this competition is not so high because we do not get much applications in this category. So I'm sure that my voice is going to reach to many of the female candidates who are sitting here, and pass this message across that Indian Council of Medical Research is really helping the country in advancing the area of the capacity building in whatever area of interest suits to you, be it a robotic, imaging, modeling, precision medicine, or whatever. So, as I said, that we have recently funded three Center for Advanced Research. All the centers list is available on the ICMR DHR website, and there is a team of researcher who is working on robotics. I remember that it's a team from All India Institute of Medical Sciences, Jodhpur, who have been recently funded one robotic assisted rehabilitation program by the team, and they're working very closely with IIT Mumbai and some other IIT Kharagpur or so. So same are the a team of researcher from neuroplasticity and BCI also. But these are the hubs. So the whole aim of having the Center for Advanced Research is that those are the hubs which have been recognized. But around those hubs, we need to, scale the whole area of these three particular domains. So with this aim, these are the Center for Advanced Research. And of course, I have already spoken about the assistive technology, but through national list of essential assistive products, which is again at par with the list which WHO has come up. So this ICMR is leading. Once the list has been identified, now those products have to go to the community for the caregiver. So the whole process of how to make those products available into the system also has to be materialized without any hiccups, so that seamless production, availability, affordability, and accessibility of those products is met within the health system. So that is the aim of next a big task to Dr. Ravinder. So as I said that we are having the regulatory frameworks also, and we do fund some of the regulatory needing regulatory pathway from clinical meat to the domestic manufacturing by standardizing the procedures. We are working very closely with the CDSCO, because some of our products, they get stuck at CDSCO, right? So CDSCO requested that why doesn't isomer scientists come and sit and process our task. So we agreed to that task, that two of our scientists, they go and sit in the CDSCO and they go through all the regulatory, because they come to know each other, that where the road hurdles would be there. So in terms of having the products are safe, they are quality products and effective products. So that is how we are working towards the collaboration with the CDSCO and other agencies which primarily focus on make in India products. I will take couple of minutes to talk about the implementation research, since I am belong to the division of implementation research. So what implementation research is? This is that integrating the interventions which are available, which are effective, which are affordable, which are tested interventions, taking it to the primary healthcare level. So I think many of you are aware that we have vertical program of the healthcare delivery system, starting from medical college, district hospital, sub-district hospital, primary care, and Ayushman Arogya Mandirs. So that is one, and we have the various national health programs, national program on deafness, national NCD program. We don't have any program for stroke and all, but of course it is a part of the NCD. So we have taken the stroke, the cancer, the cardiovascular disease, and neuro and other liver disorders as a part of the bigger umbrella, which is the non-communicable disease program. But still, there are certain interventions which may work in a smaller setting. For example, some of the institutions in Mumbai, medical colleges, they have an intervention, but they want to take that intervention to the community level. They need the whole testing approach to the health system level. So we are trying to integrate the interventions to the uh, health system setting level. So that is, we call it as a implementation research. So right now, the budget of my division is around 150 crores. We have many national health research priority projects which are going on, but they are focusing on pediatric health, because that is the major, areas of, concern to the government. The neonatal deaths and the maternal deaths, the tuberculosis, the malaria, the non-communicable, the diabetes and hypertension. We don't have any NHRP on the stroke and in neuro rehabilitation. So I think we must plan it one. So the idea is to take those interventions to the primary healthcare setting level. So that is how we did receive couple of projects on integrating rehabilitation program into the primary healthcare system level. Probably it did not make it through because of the paucity of some literature of research, or maybe the methodology, or some things would have been weak. But really we want to have such projects funded by ICMR in the future to come up. Then we have building the capacity, of course, the caregivers, not only the doctors, but the community health officers and the ASHA and the ANMs into the neuro rehabilitation program. So, if these people are not engaged into the cascade of the care, probably we will be only limiting it to the some special group of the people who will be always requiring to give the neuro rehabilitative services. So we have to transfer the neuro rehabilitative program, the capacity, to other caregivers, to the other functionaries of the health system also. So that is, we call it as a building capacity. But the whole model of integrating the neuro rehabilitative care bundle to the community or to the family caregiver still needs to have a day of the light of the day to be funded by Indian Council of Medical Research. And of course, no one is left behind without touching the artificial intelligence and precision medicine and personalized care models. And for this, we have recently renamed one of the institute in Delhi, which is now called as National Institute for Research in Digital Health and AI Engine. And the only aim of having, in context of today's conference with the neuro rehabilitation, early detection through artificial intelligence, personalized precision medicine protocols, telerehabilitation, and predictive models will be the task of this institute. So these projects are still to be, that is what I said, the center for collaborating. So you can collaborate with this institute if you have any models, so that the entire country through this national institute gears up to develop the models which will be used for the country. So these are the four domains broadly on which we need to work. We need to develop the technology which is already there. We have discussed over a period of 3 to 4 days while sitting here. And we at a policy and governance level need to listen to those policies, those innovation, those products have to be so effective. They need to have clinically validated. The data should be so robust that the health system is geared up to take up those technologies to be making as a part of the policy. So with these four pillars, that is only we can strengthen the entire system, and then we can be the global champions if we are able to address these four basic domains, addressing all these in the qualitative manner. So I would just like to end over here by saying that ICMR is really developing in its pathway, which is positioning our country through the Develop 2047 vision, a global leader where we will have a scalable and affordable and innovation driven neuro rehabilitative solutions with support of all of you. Thank you so much. Thank you, Dr. Ninmal, and thank you, audience, for your patient hearing. Any questions from this aspect or from ICMR perspective? Yes.
Madam, normally oration we don't give any question.
Oh, sorry.
Sir, can I still
Just,
ask
it's
one,
not
please?
a question, it's a comment.
It's a comment, yes. Ma'am, I've been trying to apply for an ICMR grant since a few years now. I work for Municipal Corporation Hospital. The only problem is since the last 18 years, ma'am, there are no permanent posts that have been advertised. And I've been working since the last 5 years on contract basis. So, is there any way the ICMR can mend a few rules for having us contract based employees? This is not only in Mumbai, in Maharashtra, but all over India. And the NMC is also working to get there. So, it would be an humble request from the young forum to please taking that into consideration. We would be ready to sign a bond or something of that sort, that we won't leave the institute and go till the study is not done. But if we want the young researchers to grow ahead, ma'am, you need to tweak the contract based employee things a little, please.
I don't know, it is not related to this topic, but I think I can talk to you, Aman, because for the regular positions we do advertise, but for the contractual positions, they are, there's a tenure based, it's a project based. Okay, so for regular positions, we are going with the DOPT regulations. Okay,
Ma'am,
so
I said for those who want to apply for the grants, ma'am. So the grants application are also for people who are permanent or tenured employees of the institute, ma'am.
no, it is only for the permanent employees of the institution. That we will not be able to do it because there are certain administrative and financial regulations which are attached to it. Because that is a liability of that institute. So if the institute takes the responsibility to put that applicant as a researcher, then we are open. I think there is a change in this last call also, and this call also there is a change. We are allowing the tenure based applicants also to be the researcher if the institute where you're applying takes the responsibility, and there is another co-investigator from that organization. The project has to be over in that tenure. I think that this clause has been added up.
Thank you, ma'am.
Yes. This is added up. Thank you. I'm sorry, Dr. Nirmal.
I would like to felicitate